Welcome to the second part of the lower airway lecture for chapter 1. So this one we'll finish up talking about some of the stuff in the chapter, and then after this we'll move to chapter 2 in the following week. So make sure that you go through both this PowerPoint and the first part of this PowerPoint to the version 1. Which is that previous video, just so you get the whole picture. The good thing about you having access to all these videos is you get to listen to them or retake your notes over again. In case you miss something, you can speed them up, you can slow them down. And like I said, use the PowerPoints as I purposely blank out the first couple of PowerPoints for this course, for the anatomy part of it, because I want you guys to sort of fill in those blanks. There's a lot of memorization for the first exam. When we get into the subsequent parts of this course, it's going to be more concept based, and so that's more of making sure you get the concepts and not as much just straight memorization of facts. And so this one, make sure you use whatever techniques work best for you, but that's why I purposely blank them out. So make sure you're using your workbook, make sure you're using your PowerPoints, make sure you're doing everything you can to review all of this stuff. So when we're looking at this, we're going to go over to the segments, and I will have like a little mnemonic that I use when I talk about the different segments of the lungs. So remember, there are 3 segments in the right upper lobe, 2 segments in the right middle lobe, and then 5 segments in the lower lobe, and then in your left upper you have 4 segments, and then left lower you have 4 segments. So you have that 3, 2, 5 on the right for your right upper lobe. Then you have right middle lobe 2, and then 5 for your right lower lobe. And then for left upper lobe you have 4, and then left lower lobe you have 4. You do need to know the names. I will ask you that. That will be something that I will ask of you in the chapter 1 exam. So let's get started. So this is looking at the lungs. And this is sort of just the outside anatomy of the lungs. So if you were to take a pair of lungs and just look at the outside anatomy, this is what you'd be looking at. So one thing I want to point out here is the apex of the lungs. It's the very top part here. So unlike the heart has the apex down at the bottom there. So with the lungs, the apex is at the very top at the apex. So try not to get those confused. I know you guys are going through both cardiac and pulmonary at the same time, and it's pretty easy sometimes to sort of have your brain cross those over. It happens from time to time, but overall I think you'll be okay as long as you just keep going through all that stuff. So the apex, so up here is your right upper lobe. Over here would be your right middle lobe, and then down here would be your right lower lobe, right? And then over here would be your left upper lobe, and down here would be your left lower lobe. How many segments are in your right upper lobe? Hopefully you said 3, apical anterior posterior, middle 2 segments, and then right lower lobe 5 segments. Left upper lobe 4 segments, left lower lobe 4 segments. So we have 3 lobes on the right, 2 on the left. We have 10 segments on the right, 8 on the left. And then we have 3 segments, 2 segments, 5 segments, and then 4 and 4. So I know that can get confusing, but just remember the difference between a segment is these sort of branches, right? These little branches that come off out of there. And then a lobe is this just whole area, the whole area. And so we like to look at that. So every once in a while the doctor might, especially if we have a case of non-small cell lung cancer, most of the time that occurs in the right upper lobe, and so the doctor may do what's called the lobectomy, right? Remove or part of the the lobe or all of that lobe, and so we might remove that right upper lobe altogether, and so that would be a lobectomy, right? And so that's not removing just the segments, it's removing the lobe. But let's say we use a bronchoscope and go inside the lungs with the camera and we go to the right upper lobe, then you might see the apical anterior posterior segments when the camera is, let's just say, right there. When we're looking up, you'll see those. And then when we get into diagnostics class, we'll be playing with the bronchoscope, and then hopefully you'll be seeing some videos of it too while we're going about it as well. All right, so the outside gross anatomy, just in basics, it occupies all of the thoracic cavity except for the mediastinum. Well, the mediastinum was that area in between both the lungs. That's where you have that little 4-pound structure, the heart, sitting in there. You also have the esophagus. You have the vena cavas, your superior and inferior vena cava. They all run through that mediastinum area there, right? Hopefully you're descending aorta as well, probably the important thing. Your carotids that come off your left common carotid, brachiocephalic, and right common carotid that come off your aortic arch, right? You need those that come off of there. So those are all going to be sort of in that mediastinal area, the area in between the lungs. Why do I make a big point about that? Well, because when we put someone on positive pressure ventilation, and let me just draw like a pair of lungs. And so let's choose a different color for the heart. Let's go purple. So my vena cava, my superior vena cava, my inferior vena cava, my heart, some of the carotids that lead up to the brain, all those are still occupying that thoracic space. Now, what happens when we inflate the lungs too much? What happens when we give too deep of a breath? What happens when we push the lungs as open as we possibly can in the thoracic cage? Well, there's not a lot of room in there, so that means that we can squeeze and pinch off venous return to the heart, right? We're squeezing the lungs so full, right? We're pushing the lungs so full in the thoracic cage that we're squeezing the vena cavas, which is leading blood back to the heart. Well, what do you think happens to your blood pressure if we choke off the blood flow to the heart? Your heart can squeeze as much or as strongly as it wants, but if it doesn't get blood returning to it, it's not going to put out an adequate amount of blood to finally perfuse your brain, to perfuse your organs like your kidneys, your liver, so on and so forth. And so we got to be very careful about how we, as respiratory therapists, when we're dealing with mechanical ventilation, how much pressure we're pushing into the lungs. We got to be careful, because what can really happen here is we can affect the patient's blood pressure. We can cause them to be hypotensive, which in itself is not great, but the fact that it's causing blood flow to the organs to decrease is a very bad thing, and that can lead those organs into failure, just like necrosis, right? Those organs can eventually go into failure. And this is a very common mistake that can happen even in critical care medicine today. And stay with me, because I'll talk about things, especially when we get to the VQ lecture towards the end of this course, on how to avoid this or ways to see this early on. And you'll learn this stuff in this course, in pulmonary anatomy and physiology. You'll learn things that will apply to critical care medicine. And I'm hoping that makes that transition a little bit easier when you guys get out there. So each lung has its own pleural cavity, right? So if I have a hole that develops, let's say someone does a knife stabbing, right, into my right lung here, right? So we'll say this little line there is a knife stabbing. Very violent, or we'll say it's an accident, right? Barbecue gone wrong, it was an accident. Okay, so that's okay, because one of the cool things about this is we have our own pleural cavity for the right lung. So if I puncture a hole in the parietal pleura of the right lung, that means that that hole should not take effect to the pleural space of the left lung. I hope that makes sense to you. So they're contained in each their own pleural cavity, which is kind of good. That means that we're going to limit the amount of damage that's happening. So that means if I fix whatever caused this, or I evacuate that air that got into that pleural space there, then I should correct the whole thing. I don't have to worry about that patient's left lung at all. So this is a good thing that limits damage. So each lung has its own pleural cavity. Anterior, lateral, and posterior surface are coastal and adjacent to ribs, so that's where we're looking at the ribs being a big part of how you breathe. If you were to just give yourself a spine and no ribs, you actually would not be able to breathe, even with a diaphragm. You need the rib cage to supply continuous outward tension on your lungs. Your lungs are like a balloon, right? Here, let me just draw like a weird balloon, okay? So they're naturally elastic. Remember, we talked about elastic material sort of being out on the outside of it too. So its natural state, the lung's natural state, they're introverted. They want to go in. They want to collapse. Well, what's keeping them from collapsing? Well, A, surfactant will help keep them from collapsing. Remember, that reduces the surface tension inside. But B, the thoracic cage actually helps keep that balloon inflated, because what happens here is the rib cage naturally wants to be out. It wants to be expanded. Your rib cage wants to be all the way open, right? And so what we have continuously going on, it's like the odd couple or yin-yang type situation, right? We have two opposites, right? We have one person or one thing that always wants to go out. It is the extrovert. It wants to pull everything with it. So that's your rib cage. And then your introvert, which is your lung tissue that's elastic and it always wants to snap back into its smallest state. Well, if your ribs are intact, then that's going to keep continuous pressure to maintain some patency of the alveoli, right? So you need your rib cage intact to help keep your lungs somewhat open even at the end of exhalation. So this is kind of a cool thing to think about when we're looking at the lungs. So the first breath you take when you were a baby, when you came out of mom, whichever way, right, the C-section or the other way, the first breath you took was a very, very deep breath, and it filled your lungs very deeply. Well, usually the first breath is about 40 mLs or so, and it's a lot. That's a big, big breath. And what happens there is now your rib cage, even though your rib cage at that point as a newborn is mostly cartilage, very, very soft bone tissue at that point, it still supplies outward tension to keep that lung somewhat open. It's kind of cool. So even if in post-mortem, right, even on post-mortem, you can still see that there's still gas left in the lungs of that cadaver, because the rib cage is still intact. As long as that rib cage is still intact, it's still keeping some of that lung tissue expanded. Isn't that crazy? So we have to have our own rib cage intact in order to help keep the lungs open and somewhat healthy, right? So I hope all this has sort of come together. That's kind of an important thing. The lungs will rise above the clavicle to the level of the first rib, and we'll look at this when we look at chest x-rays. And so let me draw this on here. So I'm just going to draw a clavicle that goes in here. Yeah, that's supposed to be a clavicle. And then a mediastinum. Well, let's just go. So the lungs actually go, the apex of the lungs actually go above the clavicle. So if you palpate on yourself, feel your clavicle bone, right? In fact, if you go in deep superior to your clavicle bone, you should know that the apex of your lungs even goes all the way up there. So that means, why is that important to you? Well, there's a lot of reasons why that's important to you. Let's say someone has a trauma that happened to them, or we're putting in a central line, a subclavian central line, right? We're doing a procedure, we're putting it in the subclavian vein. Well, if we're taking a giant needle and pushing it behind the clavicle to get to the subclavian vein, we can easily puncture the parietal pleura that's around the rib cage and cause a pneumothorax, even though we're above the clavicle. So knowing the gross anatomy is really going to be helpful. Even if someone has a superior wound or injury up there, they can still get a pneumothorax. They can still have pulmonary issues superiorly above the clavicle location. So the first rib is above the clavicle, and that's also a landmark when we're looking at chest x-rays. So later on down the road, and I have them on my YouTube channel too, about reading chest x-rays, and so that's something that we talk about as a landmark for where do we start the lung tissue. Well, we're going to start with looking where the first rib is, which is actually a little circle that appears above the clavicle. The concave base of the lung sits on the diaphragm, right? The diaphragm is going to be this muscle that's down here. Remember, the diaphragm is not a continuous muscle. That would be a very bad situation, because if it was continuous, you wouldn't have a thing like the esophagus, or the descending aorta, or the inferior vena cava. None of that would be able to sort of go through your thoracic cage if it was one continuous muscle. So the diaphragm itself, even though we use it as one word, the diaphragm is made up of two muscles, right? The right hemidiaphragm and the left hemidiaphragm, and it's connected in the middle by a central tendon, and it's the central tendon that has the esophagus and the descending aorta and all that stuff that we were talking about that goes through the phrenic nerve. And I have some pictures later on here, but the concave base of the lung sits on the diaphragm, and there's better pictures than what I can draw on that one, so we'll go through those. The mediastinum border, which is that central area, the mediastinum border is concave to the heart and other mediastinal structures. So that's something that we'll look at too with people that have air trapping conditions like an asthmatic episode or COPD. We'll look at their lateral chest x-ray. So in other words, instead of looking at the lungs from the front or behind, we'll actually have the patient turn to the side, and then we can see how much airspace there is underneath that is causing their issue, or how much air trapping there is on those patients. So it's kind of an interesting thing to look at there as well. So this is also an area that can affect blood pressure too. If we put too much pressure into the thoracic cage, you could in theory squeeze the heart as well and make it so the heart can't fill as much with blood, and you can make it so the heart can't get rid of as much blood, right? Because you're squeezing it. It's like going up to someone and giving them the most giant bear hug in the world. Are they going to be able to breathe very easily? No, because you're squeezing their cage so they can't take a breath in. Well, imagine you're doing the same thing with the heart, right? You're squeezing the heart from the outside with the lungs. The heart's not going to be able to expand and get a lot of blood flow, and it's not going to be able to squeeze much out, which in some cases we'll use this to our advantage. We'll purposely give a lot of pressure, not too much where it causes too bad of a situation, but let's say the heart is sick. Let's say the heart muscle itself is sick, okay? So this is all bonus content here. So I have someone that has congestive heart failure, where that heart muscle is weak and sick. If we put them on a mechanical ventilator, what happens to a muscle if we stop using it? Well, we're not talking about like atrophy. We're talking about a muscle that's worn and tired. What happens when you go run a marathon? Are you going to get up the next day and go run another marathon, or do you need to have that muscle recover? You need to have muscle recovery. And so that sort of similar situation with congestive heart failure is the left ventricle is sick. It's not squeezing correctly. And so one of the best things we can do is take the workload off of the muscle, or make the muscle not work nearly as hard. And one of the things we could do when we put those patients on mechanical ventilation is actually use a low level of pressure that puts a little bit of restraint on the heart motion that makes that muscle sort of recover, or get that muscle recovery back to the point where we can help them until their body starts healing itself, pull off extra fluid, things like that, and then we can sort of release that pressure. But we're actually using the squeezing of the heart with our ventilator to actually help in that situation instead of hurt. Isn't that crazy? So we can use it both ways, and knowing cardiac anatomy and physiology on top of pulmonary anatomy and physiology will make you that much better of a respiratory therapist. And that's my whole goal here. Is I could just talk about lungs for this whole class and I would be fine doing that. But if I don't relate it to what it means when we're talking about cardiac anatomy and how those two intertwine, it'll be worthless, right? Because I don't want you going and be like, oh, we could just increase the pressure in the lungs and that'll help get more oxygen in the bloodstream, when in fact if their blood pressure is already low, you're going to make it worse and their ability to carry oxygen is going to be decreased. So you're actually causing that patient harm. So I know that was a lot of information and you could pretty much forget all of it for now. That was very advanced. But I want you to see where this goes or why it's important, okay? So bullet points, the heart and the other structures that go through the thoracic cage, also important. And we don't want to use too much pressure, and in some cases we can use some pressure to help benefit the patient in different clinical conditions. So that is the bullet point part of all of that. If none of that made sense, at least pay attention to that bullet point part. So the heart's over there. The hilum is at the center of the border where the main stem bronchi, the blood, the lymph vessels, the nerves, all that are there, and we'll look at more pictures of that here. So this is sort of the gross anatomy picture. Please be aware and be ready that on the exam, I will expect you to remember stuff from regular anatomy and physiology. You should know the 3 parts of the sternum, like the xiphoid process, the sternum itself, right, the manubrium, right, all that stuff, how many ribs there are, how many true ribs are, how many false ribs there are. Those are all things that you should be expected to know on exam 1, and they're also covered in your workbook. Hint, wink. Hopefully you understand the subliminal message I'm trying to send there. So make sure you're going through that workbook. Make sure you're reviewing all this stuff. Make sure you know all that stuff, especially when you're looking at if you want to work at a level 1 trauma center down the road. Trauma victims, we rely heavily on our anatomy, especially if they have to crack the chest to go do an internal cardiac massage, things like that, stabbings, gunshots, traumas, crush injuries, all those things, even putting in a tracheostomy tube. They're all things that are going to require a good foundation of anatomy and physiology. And ultimately, when we talk about advanced things like mechanical ventilation and pharmacology, you have that strong base of anatomy and physiology of both the cardiac and the lungs. You're going to be set up for a huge success, and things will come a lot easier when you go to those courses as well. So just make sure you're going through those, make sure you're giving yourself a good base here. So this is the posterior and anterior view of the thoracic wall. So we're looking at the body of the sternum, the xiphoid process, the manubrium, the sternal notch and the clavicle. Remember the apex of the lungs goes above the clavicle there. And that's how we usually see rib 1 when we're looking at x-rays. Another thing to pay attention to on the anatomy and physiology, when we go to listen to lung sounds, breath sounds on someone, usually one of the first unique things that I see someone that's newer to the field do, and even physicians do it here and there, is they go to listen to someone's lung sounds on the back of their chest wall. So if you have a stethoscope at home, or when you do get one, when we do listen to breath sounds, you want to make sure you're listening in between the scapula and the spine and in between ribs. So if I want to listen to someone's upper lobe, I'm going to listen in between the ribs as well as in between the scapula and the spine. And a common mistake I see out there is people trying to somehow listen with their stethoscope over a scapula. I'm like, wow, what type of breath sounds did you hear? And so it's always interesting. They would be like, I didn't hear much. They must not be breathing very deep. And I'm like, because you're listening over a bone. So don't do that. So word to the wise, when you go out there for your clinical rotation, when you listen to their lung sounds, keep in mind not to listen over bone. You'll hear breath sounds a lot better if you don't. I'm just saying. So these are the ribs, ribs 1, 2, 3, 4, 5, and then 6, 7, 8, Then the rest of them are not pictured here. So make sure you know your basics anatomy here. I do not have any labeling for you on the exam. I hear a bunch of hoorays, right? Right? Or an amen or whatever it is, right? I won't make you label, but I have other ways of making sure that you understand this information. So don't think that you can't know what is located where. All right, so this is just the lungs themselves. So that was the thoracic cage, the anterior and posterior view. And then now we're just going to look at the introverts themselves, those lungs, right? So one of the big things I want to point out on this one are going to be the fissures, right? These guys here. You have 2 on your right and 1 on your left. So the 2 lower ones are the oblique fissures. So the fissures are what separates one lobe from another lobe. So when we're looking at the oblique fissure on the left lung, so it separates the left upper lobe from the left lower lobe. So down here is the left lower lobe, up here is the left upper lobe. So you can even see this if you guys do a cadaver lab, or if you do like the pig lungs things, you'll see that fissure is what separates those. So we can even have conditions, and so I can have a severe pneumonia where I just pretty much have most of that bacteria, let's just call it bacterial pneumonia, that's just brewing and festering in my left lower lobe there. And so when we look at the chest x-ray, that whole left lower lobe will be pretty much opaque. It'll be whited out because it's so dense, right? It absorbs so much of the x-ray itself. And then we're going to see a big contrast between the left upper lobe and left lower lobe. Well, why wasn't the left upper lobe affected? Because we have that fissure, we have that separation of tissue there. And so the fact that we can see that fissure, which normally you can't on an x-ray, normally there should be no difference in between the two. The fact that you can see that contrast means they might have what's called a lobar pneumonia, right? Because that would mean that whole left lower lobe has a pneumonia going on. Even the right lung, the right middle lobe can even have this too. People that have asthma can easily have what's known as right middle lobe syndrome, and we'll go over that in disease class. So the fissures here are something to pay attention to. So you have oblique fissures on both the left and the right side. And then on the right side, since you have 3 lobes instead of 2, you also have the horizontal fissure. So the horizontal fissures, right, separate the right upper lobe from the right middle lobe. So right upper lobe from the right middle lobe, right? That's what it's separating, the right upper from the right middle lobe. The oblique fissure, actually, now think of the lungs as a 3D thing. I know you're looking at a 2D picture, right? So this is a 2D picture of a 3D object. Okay, right. So now I want you to think of the lungs as a 3D object, right? I wish you all had like an actual pair of lungs that you could handle here, like whether it's like pig lungs or whatever, right? Because this is a 3D object, and it's going to sound weird, but think of this as a 3D, almost spherical object. The oblique fissure on the right lung separates the right upper lobe from, the right upper lobe and right middle lobe from the right lower lobe. So it separates the right upper lobe and middle lobe from the lower lobe. So both of those together from the lower lobe. Now I have a better picture upcoming of that sort of shows it as a side view from the hilum, but I want you to sort of start with that mental picture right now, that it separates both the upper and middle from the lower, okay? And this is because it's a spherical object. It's not going to show up well in the picture. The picture here, you're looking at the oblique picture, and you're looking at the oblique fissure of the right lung, and it says, okay, the right middle lobe and the right lower lobe, and it just separates the two according to the picture. But because this is a 3D object, it's actually the right middle and upper over the right lower lobe. Okay. When we get into x-rays down the road, we'll talk about a sulcus sign and what that means and how we can tell on an x-ray if it's the right middle lobe versus the right lower lobe. So we'll get there eventually, but I want you to understand the oblique fissure in the right lung, right upper and middle, separating from the right lower. Okay, so this is a better picture. I like this side picture. When we're looking at this, the fissures from the side here, so this is actually looking at the hilum. Remember, the hilum is where all these things get put back into the lungs, like your pulmonary artery, your main stem bronchi, all that stuff, where it's going into there, the pulmonary veins that drain good blood back to the heart. All that stuff, that's where it goes through, is that hilum area. And so this is a good view of actually that hilar area of all those vessels that just go through to each lung to do what they need to do. So the hilum is where the great vessels enter the lungs. So we're looking at it here. Once again, this sounds important, almost like it could be a test question. The hilum is where the great vessels enter and exit the lungs, right? That the pulmonary artery, the pulmonary veins, your main stem bronchi also here, they're not considered great vessels, but your pulmonary artery and your pulmonary veins are going to be some of the big ones here. And so here you see the horizontal fissure. All right, I'm highlighting it now. And then here, down here, you also see, when we're looking at this one, the oblique fissure. Remember, the oblique fissure separates the right upper and the right middle from the right lower lobe. Isn't that crazy? So it's a little bit of a better picture. This is the oblique fissure, of course, it's being pointed out. Now the oblique fissure on the, let's go to yellow. The oblique fissure, it's pretty easy on the left side because it just separates the upper from the lower, left upper from the left lower. But the oblique fissure on your right lung, remember, it separates. See how it runs obliquely? Going back to the skeletal system, just saying. It runs obliquely. It separates the right upper and the right middle lobe from the right lower lobe. So the right lower lobe is actually posterior. So if you were to listen to breath sounds on someone and you were listening to their back, right, in between their, under their scapula, so not on the scapula, but under the scapula on the back, you're actually listening to the right lower lobe. Now anteriorly, if you were to take the stethoscope and listen anteriorly on the rib cage, you're actually probably listening to the right middle lobe, right? We're talking about the right side here. So the right lower lobe runs posteriorly, the right middle lobe and the right upper lobe run closer to more of an anterior situation. I hope that sort of makes sense. Like I said, it's tough for you guys, especially since you don't have a 3D object to hang on to look at this. So please try to pay attention to this. Make a note to yourself to look for the different lobes and stuff. If you guys get to go to a cadaver lab or play with the pig lungs, right? Try to look for those fissures, their segments, and sort of see hands-on that 3D thing. So that way, when you're in a bronch and they're talking about going to the right middle lobe and they go anteriorly, you'll understand, oh, the right middle lobe is anterior, so we have to do that. So we'll look at that. All right, so the side view here, this is the right lung. I know I'm making a big deal over the right lung, but there's usually a lot of confusion on this, so I'm going to do as much as I can to make it as repetitive as I can. So the right lung is larger. Oh, let me switch colors here. Larger. So the right lung is larger and heavier. I'll just put the letter H in there. It's larger and heavier than the left. Right? You have three lobes on your right in 10 segments compared to 2 lobes in 8 segments. So the right lung has more mass. It's heavier, it's larger, right, than the left. The right lung has how many lobes? 3 lobes in upper, middle, and lower. the lobes are divided by the oblique fissure, which divides the upper and middle lobe from the lower lobe, right? From the lower lobe. So upper middle lobe from the lower. So as we look at the picture, so look at the picture over here. Here's the middle lobe and the upper lobe. They're labeled as superior. Let's go to yellow here. So this would be your oblique fissure here. See how it separates the upper lobe and the middle lobe from the lower lobe? So this would be posterior, and then this would be anterior. Hopefully you're starting to get a better picture or grasp for this. Doing the best I can. But the easy way to remember that this is the oblique fissure is that it runs obliquely, right? Just like when you went over the skeletal system, right? That's what runs obliquely, right? And this also means, the next bullet point over here, the horizontal fissure, which I already have a line there. That's cool. The horizontal fissure divides the upper lobe from the middle lobe. So the horizontal fissure is this one here. So I'll just put the letter H there. Horizontal, which I already have a horizontal line over there, so that worked out pretty well. So hopefully you remember who separates what. So if I ask you about the oblique fissure in the right lung, it separates the right upper and right middle from the lower lobe. If I ask you about the oblique fissure in the left lung, you would say it separates the upper from the lower, left upper from the left lower. If I ask you about the horizontal fissure in the right lung, it separates the right upper lobe from the right middle lobe. Okay, so make sure you write those down. Make sure you put that on a 3x5 card, Quizlet, however you do it. Make sure you got that down. Make sure you know who separates who, especially in clinical practice down the road, and this is just more of an application point. If we do put in a chest tube, let's say there's a giant effusion of here that's a transudate, an exudate fluid, right? A very thick, pussy, infected fluid, and we need to drain it. Well, we need to make sure we're going into the right place. Are we going to go into the horizontal fissure, or are we going to go into the oblique fissure? So you sort of need to know where you're going anatomically before we start poking holes in things. Okay, let's move over to the left lung. This guy's a little bit simpler. I love this. And then here's your oblique fissure. It runs obliquely. Right. Thanks, anatomy and physiology. The left lung is smaller than the right lung. It only has how many? 2 lobes? 2 lobes. An upper lobe and an indentation called the cardiac notch. And that's this whole area here. This is that whole cardiac notch, right? Where not only your heart, but also your aorta, pulmonary artery, and all those stuff are going to be. You also have like your thymus and some lymph tissue and things like that in there as well. So primarily this is considered where the heart sits. That was supposed to be a heart, right? Good thing this is not art school. All right. The lobes are divided by what fissure? That is going to be the oblique fissure. O-B-L-I-Q-U-E. Oblique fissure. Okay, the lung segments. This is where we're going to have some fun. Like I said, I do need you to know the names of the segments of the right upper lobe. I need you to know the segments of the right middle lobe. I need you to know the segments of the right lower lobe. I need you to know the segments of the left upper. And same with the left lower. You need to know the names of the segments, how many there are in each lobe as well. So let's get into it. All the lobes are further divided into segments. There are 10 on the right, 8 on the left. Those are numbers you need to remember. So be careful with the numbering systems. There are, and when you look at your book, you might see some conflicting information as well. This is what is on the board exams. This is what's on physician exams. This is also what's on your respiratory therapy board exams, that you have 10 on the right and 8 on the left. You might see it where it says 10 and 10. And I'll tell you about where that's sort of coming from. In the left upper lobe, you have a almost like a dichotomous branching where and there's a better picture of it somewhere else. You have like a dichotomous branching where you'll have a left upper lobe where you have your 4 segments in your left upper lobe, but 2 of those 4 segments have another branch on them. So some people count those extra branches, those extra 2 little branches, as extra segments. Well, critical care medicine and all the people that do both critical care board exams as well as your respiratory therapy board exams do not count those. So you might see in your text where it says 10 on the right, 10 on the left. However, for board exams and what I'm going with, because I want you guys to do well on your board exams and have good quality information, I want you to do 10 on the right and 8 on the left. Remember, it's just those extra 2 little sub branches in the left upper lobe that they're counting as an extra 2 segments. So this is a picture from your book where you're looking at the different lung segments. And I do have a mnemonic that might help you here as well. So I'll go to, and I put 2 blank slides in this presentation. When we go through this, I'll sort of show you the mnemonic I use. This is something that they classically ask on in Sputable 2. They'll ask you name the segments of the right lower lobe, right? And so then you have to name all the 5 segments of the right lower lobe, right? So when you get out there, right, the lung segments are going to be very helpful, not only for board exams, but also, like I said, for things like bronchoscopies, for therapeutics, when you're talking about draining different lobes and segments, you're going to need to know these. So I know this is difficult, but understand that I do have that purpose for you. So let's go to the side view, and this is just a color-coded picture. I like how the color-coded picture, but if the color-coded picture is a little too much for you, that's okay, right? But you don't need to color them in for me. But the color-coded picture sort of gives you where those individual segments go. All right, so let's start with the left lung. All right, let's start in the easy place. So I always look at this, and you can use this or not, as remembering the mnemonic Asia, Alps. So let's go purple here. Asia, and then Alps. Okay, so Asia, Alps. Okay, so we know how many segments are there in the left upper lobe. So we're starting with the left lobe, okay? We know that there are 4 segments in the left upper and 4 segments in the left lower. Okay, notice that there's 4 letters in Asia and 4 letters in Alps. Okay, like I said, if this helps you, great. I won't test you on my mnemonic. I just want you to know the names of them. So if you use the mnemonic, great. If you don't, you'll still be okay if you somehow memorize it a different way. Okay. So Asia, Alps. So let's look at the left upper lobe first, which is Asia here. So when we're looking at the left upper lobe, we have 2 and 2. Okay, so we have the apical / posterior and anterior. So we have the apical, apico-posterior. So apical, posterior, and like I said, some people count that as 2 separate segments. For our purposes, we'll count it as 1. The other one that's up there is the anterior. So apical, posterior, and anterior. That's 2 segments, right? 2 segments. The other 2 segments that are in your left upper lobe are your superior lingula Lingula, and then your inferior lingula. superior and inferior lingula. So those are the other two segments in your left upper lobe. So Asia, apical. So it's a little out of order here, but apical posterior, superior, right? Superior lingula, inferior lingula, and anterior. Those are the four segments of your left upper lobe. So apical posterior, anterior. Let's do a different color here. Let's do blue. Apical posterior, anterior, superior, and inferior. I hope that sort of makes sense. This is just the way that I remembered it. Like I said, you can use different ones out there. And then Alps, remember you have four segments in your left lower lobe. So Alps is your left lower lobe. So this one is a little bit easier. A is for your anterior medial basal. Anterior medial basal, right? Anterior medial basal, so that's the first one. The next one is going to be, and these go in order on this one, L, which would be your lateral basal. Because it's in the lower lobe, it ends with basal, right? It gives it that last name. The next one is P, so that is your posterior basal. And then finally, your superior basal. So, what are the four segments in the left lower lobe? Anterior medial basal. So it's the anterior medial. There's a slash there. That's what the second one. So remember, in the left upper lobe, we have the apical posterior that some people count as 2. In the lower lobe, some people count this anterior medial basal as 2. That would then equal 10 segments. However, most sources actually combine those two, so now there's only 4. Those two are combined as 1. So in your left lower lobe, you have your anterior medial basal, lateral basal, posterior basal, and superior basal. And then in your left upper lobe, you have your apical posterior, your superior lingua, your inferior lingua, and your anterior, right? Your anterior segment. So let me ask you this. If we're in a bronchoscope, okay, and so these just combine. So we're in a procedure, a bronchoscope procedure, and we go in and we see 2 segments in the left lung, and they have a pulsing to them. You can see cardiac movement, and this is true. This is absolutely true. You can go look at some YouTube videos of bronchoscopies in the left lung. And when they get to the lingula here are very, very close to the heart, right? And you can actually see cardiac oscillations. That's supposed to be heart. I have to work on that. It's going to be one of my goals for the year. You can see cardiac oscillations. You can see their pulse from the inside their lungs. And so I can actually see 2 little tunnels in the distance. And if I see pulsing, I know we're looking at the lingula. We're looking at the superior and inferior lingula. If I see 2 tunnels in the distance and we know I'm in the left upper lobe, then I know I'm up here where my apical, posterior, and anterior segments are. So I can sort of know. So let's say the doctor wants to get a sample from the patient, and I see pulsing and 2 little tunnels in the distance, and I know we're on the left side, then I'm going to label that sample, and you will be responsible for this, labeling the sample for the superior lingula and inferior lingula, right? So this is something that will come into play. Okay, we're in the bronchoscope, we're on the left side, and we see 4 segments. We see 4 segments or 4 tunnels in the distance. Then I know that we are in the left lower lobe, right? Then that's where you have your anterior, lateral, posterior, and superior basals going on. So anterior medial, lateral basal, posterior basal, and superior basal. So like I said, you do need to know these when you get into therapeutics. You'll need to know by what position someone's in, right? They'll show you a little picture of someone laying down with a pillow underneath their hips and so on and so forth. They'll ask you which segment is being drained, or which one is like being affected by gravity, right? So this is something that'll make that class and that part a little bit easier. So let's go from the left lung to the right lung. So the right lung, this is going to be a little bit longer, but sort of stick with me here. I do a palm seed makes another little palm. Okay, whew, I know that was a lot, but trust me on this. All right, a palm. Where are we at here? Would you believe my handwriting is actually better on a regular whiteboard? Makes another little palm. Okay, so remember this is supposed to be the right lung. We have 3, 2, 5, the right upper lobe, the right middle lobe, and the right lower lobe. So let's start with the right upper lobe. So we know that there's 3 in the right upper lobe. There's 3 segments. You have your apical, you have your posterior, and then you have your anterior. Okay, hopefully. Do you guys sort of see that? You see what I did there? Apical, posterior, and anterior. Okay, right middle lobe. We know the right middle lobe has 2. So we'll just do a little. The right middle lobe, well, I think it has a lateral and then it also has a medial. So it has a lateral and a medial segment. Do you guys see where I'm going at here? See the capital letters correlate with these? So apical, posterior, anterior, those are my upper lobe. My lateral medial would be my middle lobe. And now, seed makes another little palm. That's a lot more letters than what's in the right lower lobe. But notice what's capitalized here, okay? So that's on purpose. We know there are, in the right lower lobe, 5 segments, okay? That would equal 10 on the right side. So on here, I'm going to look at S. What would S be? Right, my superior basal. Superior basal. M would be my medial basal. I ran out of room there. Superior basal, medial basal. What would A be? Anterior basal. L would be my lateral basal. And then finally P would be my posterior basal. So like I said, this is how I remembered it. I would be in a speedable competition and they would say, name the segments of the right lower lobe. And beforehand, you can go up there and write down whatever you want on a blank piece of paper. And I wrote, a palm seed makes another little palm in Asia Alps. And so they would ask, what are the segments of the right lower lobe? Well, hey, I already knew there were 5. And then I wrote, a palm seed makes another little palm. So I'd be like, hey, superior basal, medial basal, anterior basal, lateral basal, and posterior basal were like that. And people look at you like, how did you know that? And I'd be like, I know that palm seeds make another little palm. and that they just look at me like I'm crazy, which that's a whole debated topic on itself. But I hope you guys didn't get too lost with this. Like I said, if this doesn't make sense to you using this mnemonic, that's okay, right? I'm not going to test you on mnemonic, but I will test you on knowing what are the lower segments of the left upper lobe. Well, that would be your lingula, your superior and inferior lingula. I might ask you, what are the segments of the right lower lobe? What are the segments of the right upper lobe? As long as you know those, that's sort of the key thing that we're looking at here. Not only how many segments are in each lobe, but also the names of those segments. So if you want to use a palm seed mixed in a little palm in Asia Alps, that's perfectly fine. That's just up to you. Another one for the left side was astute anatomists share inside secrets about lung purposes. Right, so that was another one that was out there. So you pick your choice, however you want to do it. I'm just sort of sharing with you what I had used as a student. All right, back to the regularly scheduled program. Mediastinum overall, this is a cavity that contains the organs and the tissues in the thoracic cage between the right and the left lung. This is a very important area, especially if someone has air that escapes their lung. If we have a pneumothorax, like let's say we put too much pressure into the lungs with the ventilator and we pop a hole and some of the air goes into the mediastinum, do you think that air can eventually crush like the aorta and the pulmonary artery, right? It can easily put pressure on those things and cause an issue with their blood pressure. So the mediastinum is a very important thing, especially when we're looking at things like the esophagus and the nerves that run through the mediastinum. Those are all very important things. So this can come into pretty good handy. So this is in between the right and left lung. It's bordered on the anterior part by the sternum and the posterior part by the vertebrae. Those are what protect it on the anterior and posterior part. It has the trachea, the heart, the great vessels. We talked about the aorta and the pulmonary artery. They enter and exit the heart. You have the esophagus, the thymus that runs through here, which on babies is big on their x-rays, right? If you want extra like little thing to go look at, Google image sailboat sign or sail sign for a baby, and you'll see it looks like the triangle sailboat sign. That's the thymus gland on babies. So it's very, very big and can be noticed there. So something a little extra for you to do on your free time. Little joke, because free time in first semester is pretty rare. The esophagus, the thymus gland, lymph nodes, and nerves, all those things will run through this area. So it gets to be pretty important when we're talking about function of the whole body and how things that we do that put too much pressure there, or things that the patient has going on like asthma or COPD, can put pressure on those areas and really affect someone's overall health significantly. So this is a picture. We're looking at the hilum here. You see how the hilum goes right here and right here. That's where everything's entering and exiting. Not a good picture showing everything there, but this whole area here is that mediastinum. Let's go to yellow. Whole area here is that mediastinum, right? And remember, the diaphragm is that concave base part down here. And you want to see that concave, you want to see that arch. I always talk about it being like the McDonald's arches, but that's a little old school because they don't really do much of the arches anymore. If you don't see arches, that means those diaphragms are flattened out, and that could be a sign that someone has gas that's being trapped in their lungs. Isn't that crazy? I like this picture also showing the pleura, right? So I can see the parietal pleura, which surrounds the perimeter. That's how I remembered it. You can remember any way you want, as long as you remember it somehow. The parietal pleura surrounds the perimeter. I think of the perimeter being like, you know, the fence of your yard or whatever, right? It aligns the perimeter, so it's the inner lining right under the rib cage. Let's go to yellow again. So right under the rib cage here. Right, that's surrounding the perimeter, that's protecting gas and all that stuff from getting into the pleural space, right? It's that last thing right underneath the ribs that sort of keeps that chamber sealed. Then you have the visceral pleura, which lines the lung tissue itself. And it even goes into the fissures. So the lung tissue, like I said, it even goes into the fissures. So you have your parietal pleura, which I remember as being the perimeter, and then the visceral pleura, which then by logic is whatever's left over, which would be the lining of the lungs there. So we can have, and why is this important? Well, we can have issues, and as I was talking about before, you will see this in your practice out there, is if we have a hole that develops in the parietal pleura. Right, we have a giant hole that develops out here. Let's say it's a trauma. They fell on something and it poked a hole in their parietal pleura. Well, now gas, the pleural space itself is going to have negative pressure in it. It's going to be negative, which is what causes you to breathe, because you have your chest wall that's pulling out, and then you have your lungs that's collapsing in. So because both of those are moving apart, those are supposed to be arrows, both of those are moving apart, it actually creates suction. It creates a negative pressure area in between the two because they're both pulling apart. It's like a tug of war, right? And so if there's a hole in the parietal pleura up here, now gas flow or barometric pressure will be higher on the outside of the patient than inside, right? There'll be a pressure gradient, and therefore gas flow from outside the patient's chest wall will then rush into the pleural cavity, right? Because of that tug of war, it creates that pressure gradient. And so the hole in the parietal pleura will cause an open pneumothorax. If there's a hole in the visceral pleura, so the visceral pleura is what lines the lung. So let's say we set someone's breathing machine with too deep of a breath. If we put too deep of a breath on that person and there's a hole that develops because of it, then there's still negative pressure in that pleural space, and we're still going to push a bunch of air into that pleural space, which will then crush the lung tissue in. So both ways are bad. There is a third type, but we won't talk about that here, where your body has it has a bacteria or something that's producing a gas that's in the pleural space, can cause a pneumothorax there, but that's not something I'm going to expect you to remember here. But know which one's the parietal pleura, and it's in the inside of the ribs, and then you have your visceral pleura, which is on the lining of the lungs, and even goes into the fissures. So this is just sort of covering what we just talked about a little here. You have two humidified slick surfaces of the membranes. There should be that fluid. It's normal to have a little bit of fluid in between the visceral and the parietal pleura, just a little bit. You don't want to build up a fluid here, but it's just like this one's more like oil and grease in your engine that keeps the parts that are continuously moving from rubbing and causing damage on each other, right? This helps reduce that. So it's normal to have these surface membranes be slick and have a little bit of fluid in there. If someone is severely dehydrated, they might get what's called a pleural friction rub, and you can actually hear when they're breathing in the actual like rub. It's like two pieces of leather sort of like moving against each other. It's a weird sound. And then hopefully in a patient assessment you'll get to listen to the lung sounds CD-ROM out there too. So when we're looking at the pleural membranes, the pleura that covers the thoracic wall and the superior diaphragm and the lateral portion of the mediastinum, which one covers the inside of the rib cage? Right, this one would be your parietal pleura. So P-A-R-I-E-T-A-L. So that's the parietal pleura. And then the pleura that's attached to the lung surface itself and goes into the fissures, this would be the visceral. So V-I-S-C-E-R-A-L. So V-I-S-C-E-R-A-L. So the parietal pleura and the visceral pleura. The visceral is, remember, very close to the lung. The parietal is the perimeter one that goes along the chest wall. The potential space between these two, and I will say this is also important to remember, the space between, like, could be a good test question. The space between the two, the visceral and parietal pleura, is called the pleural cavity. It's supposed to be PC, or the pleural space. So pleural cavity or the pleural space. So the thing that sort of separates the two are a thin film of serous fluid. Like I said, it's normal to have a little bit of fluid there. It would be bad if you didn't, because then you can have some trauma going on even with normal breathing. And that fluid allows the lung and the chest wall to sort of glide over each other while you're breathing in and breathing out. Right, that's normal. That's good. You want a little bit of fluid in there, just sort of like you want cartilage in your knees, right? You want something in there to sort of cushion that motion and that synovial fluid and all that stuff. So the pleural membranes hold the lung tissue to the surface of the thorax and the diaphragm, which allows for the lung to expand when we're breathing in. Like I said, you have your lungs that naturally want to collapse in. And then you have your rib cage that naturally wants to pull out. And because these two are placing that tug of war there, that creates a vacuum in that pleural space. It creates that suction. So if your rib cage, if your diaphragm moves down, it's actually going to increase volume within your rib cage, and that allows for more suction to be created, and therefore it's going to have more suction on the lung tissue and therefore expand the lung tissue. So it's actually your rib cage is what's causing you to breathe in now. Because you contracted your diaphragm, your rib cage won in that tug of war battle because the rib cage naturally wants to go out. So when your diaphragm contracts and moves down, it allows the rib cage to expand, and therefore the expanding of the rib cage opens up the lung tissue. Well, remember from physics class, oh yes, there's this law called Boyle's law. And Boyle's law, if you know it, remember pressure and volume are inverse. So if I have something where I increase volume, like let's say my lungs increase in size, right, I'm breathing in, then the pressure inside my lungs decreases, right? The molecules are further apart, therefore pressure decreases. So if I have very low pressure now in my lungs, it's going to cause negative pressure compared to atmospheric pressure. Therefore, gas will flow into my lungs. Isn't that crazy? So your rib cage, because the diaphragm contracts, the rib cage wins the tug of war battle, and it actually causes a chain reaction where you breathe in. When I reach equilibrium or equal atmospheric pressure within my lung tissue compared to the atmospheric tissue, what's going to happen? Well, I'll reach equilibrium. My baroreceptors in my lungs will be like, you're good, you've reached equilibrium. And then my diaphragm's going to relax, which will then decrease the volume of my lungs, which when volume decreases, pressure, well, the molecules are closer together, the pressure will increase, and therefore I'll have a bunch of positive pressure that goes on in my lung tissue, and I'll have higher pressure in my lung tissue because of the elastic recoil than I will in the atmosphere, and it'll actually force the gas out. Isn't that crazy? And we'll go over this more, but that's just a little bit of a preview. Okay, so this is just a different picture showing the membranes, the visceral and the parietal pleura. Remember, the parietal is on the outside, the visceral is on the lung tissue itself. And then this is the diaphragm, much better picture of the dome-shaped diaphragm here. And remember, it's not one continuous muscle. You have this central tendon that's in between the two. That's where your esophagus and your descending aorta and your phrenic nerve and vagus nerve and all that stuff runs through there. That's why slow, deep breathing, like the yoga breathing, will actually decrease your blood pressure because it actually massages your vagus nerve. If you use that deep belly breathing, it'll actually massage your vagus nerve, which will then cause parasympathetic stimulation, which will then decrease blood pressure and more calmness, all that stuff. So good to do that during a high stress test, just saying. All right, so let's look at this one here. When we're looking at this, we're looking at, because the lungs have a natural tendency to collapse. So I might ask you in the near future, what do the lungs have a natural tendency to do? Or the lungs have a natural tendency to collapse, true or false? You would say true in that situation. And the thorax has a natural tendency to expand, right? So those are things that I could ask you. This creates that push-pull, that tug-of-war creates negative pressure between the two layers. So that the space in between the visceral pleura and the parietal pleura is a vacuum. It creates a vacuum. And if we put a hole in that vacuum, it's going up a hole in the outside of that vacuum of space. Gas will rush in because remember, pressure of any fluid or anything like that will go from high pressure gradient to a low pressure gradient. So if I have higher pressure in the atmosphere than I do in a negative pleural space, the atmospheric pressure is going to rush in and try to reach equilibrium. It sees opportunity. So should air enter the space between the pleural membranes, this could create a condition known as, and this was on your midterm packet, there was many reasons why I wanted you to do the midterm packet, known as a Pneumo Thorax. I just wrote PTX, which is the short version of it. Pneumo, PneumothorAX. So that's a pneumothorax. Right, so hopefully you just remember that. Here's a better picture of it in the next slide. Yeah, this is a way better picture. So this is what would happen if we had a hole that existed from the outside. So let's say it's the knife from the previous picture. Gas pressure is higher. So let's say our atmospheric pressure is 760 millimeters of mercury. And then the pressure inside our lungs was, let's say it's 730. So let's just... So we have a pressure gradient where I'm going from 760 to 730, so gas will rush in because I have a lower pressure there. So when it goes in, it's going to keep going in, and what happens is that pressure fills up like a balloon and will eventually crush, and that's why you see the lung. See how small the lung got here? See how small the lung got here? It'll actually crush that lung tissue, and also notice what's happening to the mediastinum. The mediastinum is actually shifting over. It's called a mediastinal shift or a tracheal deviation. And this is a board exam question. They'll ask what are some of the signs of a pneumothorax or patient's trachea or mediastinum is shifted to the left. Which side would the normal thorax be? Well, it'd be on the right because remember everything here is pushing all that stuff out of the way. Pretty crazy, huh? So let's talk a little bit about the diaphragm itself. The diaphragm is the major muscle of inhalation. Looks like this would be an important thing to remember. The diaphragm is the major muscle of inhalation. It is dome-shaped. It is muscle between the thoracic cavity and the abdominal cavity. There are two separate muscles. It is not one continuous muscle. Notice I've repeated that now. Two separate muscles. The right and the left hemidiaphragm is joined midline by the central tendon. So central tendon. So the central tendon is what connects the two hemidiaphragms together. So that way the central tendon will allow the esophagus, the aorta, the nerves like your vagus nerve and your vena cava, your inferior vena cava, all that stuff to pierce there or to go through there, so that way we can live. So remember, it is not one continuous muscle. It is two separate hemidiaphragms. And one of the things here that can happen is someone can get a paralyzed hemidiaphragm. You'll see it in some spinal cord injuries. And even with the paralyzed hemidiaphragms, the patient can still do well on some of these patients because the other diaphragm is still working, right? So it's not something that's life-threatening. They are more prone to things like pneumonias and things like that. It's innervated by what nerve? Hopefully you guys remember this from regular AMP. I'm pretty sure you guys went over it there, but if not, you'll go over it again here. Phrenic, P-H-R-E-N-I-C, the phrenic nerve. The phrenic nerve and the lower thoracic nerves contribute to the motor innervation of the diaphragm. So if we have a high C-spine injury and we have a phrenic nerve injury, we may not be able to send impulses, efferent impulses that reach the muscle of the diaphragm to contract. Now, one of the things I want to make sure you understand here is that the diaphragm is what type of muscle? Remember, the options are skeletal, cardiac, or smooth muscle. Which one is it? It is skeletal muscle, right? The diaphragm is skeletal muscle, which, what does that tell you? Just like the muscle of your legs, just like the muscles of your arms, this muscle, it can be prone to fatigue if overused, right? So if you're normally using your legs and your arms, you're not doing anything abnormal, then those muscles aren't going to go into fatigue. But you go and run a marathon, those muscles go into fatigue. So let's say someone has a severe pneumonia and they have to work harder to breathe because of what's happening in their respiratory zone. All that inflammation's happening in their respiratory zone of their lungs. So they're going to have to create more negative pressure in their lungs. So their diaphragm's going to have to contract harder and it's going to have to work harder. Well, is the diaphragm prone to fatigue? Well, it is skeletal muscle, and yes, if you do overuse it, if you do hyperextend it past its capabilities, it can go into fatigue. So that person can ultimately go into respiratory fatigue or respiratory failure, where they may not be able to exchange gas anymore. And so that's something that you need to be aware of. So when we put people on mechanical ventilation because they have something like a pneumonia or even a viral pneumonia, right? Their diaphragm's been working hard and hard, like it just ran a marathon and it needs that recovery. And when we put someone on mechanical ventilation, we put someone on life support, we're actually taking the workload of breathing off of the diaphragm and telling our ventilator to do the work for it. So we're letting the diaphragm recover from that marathon. I hope that makes sense, right? So I hope you sort of get how we can use mechanical ventilation and positive pressure based upon anatomy and physiology to help the heart recover, as well as to help the lungs recover. And pretty much the diaphragm is your primary muscle of breathing normally. Now you do have accessory muscles, but we'll just talk about the diaphragm here. It will help both the heart and the lungs sort of recover, because now we have a machine that's sort of taking the workload, that physiologic workload, off of the body, so the body can spend more energy in healing and not as much as trying to compensate for a condition. Isn't that cool? The phrenic nerve, this is important to remember. It sounds like this could be a test question. When we're looking at the phrenic nerve, this is going to be your primary nerve to contract the diaphragm and go down here. And there's even something called the diaphragmatic pacer. Now, if you're really interested in all this stuff, just like a cardiac pacemaker, they do diaphragmatic pacers. And at Swedish Medical Center, they used to do this on some spinal cord injury patients over there. And even Christopher Reeve, right, the guy that used to play Superman, was actually one of the patients that had a diaphragmatic pacer put in place. He had an injury and there was still phrenic nerve intervention. So if there's phrenic nerve intervention but they can't use it to breathe, we can actually put a pacemaker there and signal the phrenic nerve to then the phrenic nerve telling the muscle to contract. So we can actually take someone that was previously dependent on mechanical ventilation to stay alive, and then after the procedure, they will be off of the ventilator. They'll be breathing on their own because they have this diaphragmatic pacemaker. So it's pretty cool, and we're using the phrenic nerve. And if the phrenic nerve is not intact, if it's not something that is capable of transmitting a signal, then it's not an option for them as of recording this video. But pretty cool information, something to think about. All right, so how do you breathe in? Okay, so remember, when we're breathing, it's not necessarily the constitution of the gas that we're breathing in. So remember, when we're breathing, normally we're breathing mostly nitrogen, 21% oxygen, but most of it's like 79% nitrogen. It's not necessarily the oxygen concentration that we should be looking at. It's actually the barometric pressure, or the exchange of atmospheric pressure, that we're dealing with for you to naturally breathe right now. Hopefully none of you are on a ventilator right now, so I'm assuming you're all breathing just normally. So this is the inhalation pathway, right? So this all starts with the diaphragm. When the diaphragm is stimulated to contract, right? So when the diaphragm is stimulated to contract, it moves down. There's my arrow. The diaphragm moves down. Because remember, when something contracts, the muscle gets shorter, right? So when it contracts, it'll get shorter and pull down, okay? So it'll get shorter and move downwards. This will increase the thoracic volume. So volume increases. So what happens to pressure? According to Boyle's law, if temperature and mass are constant, if my volume increases, my pressure decreases, right? So my alveolar pressure, or pressure inside my lungs, all this pressure becomes negative. It decreases pressure in my lungs, right? Because we've increased the volume of the container, which is our lungs. We've increased the volume, and therefore we've moved all those air molecules apart. And therefore we've decreased alveolar pressure. We've decreased pressure inside our lungs. Okay, so now we have a very low pressure in our lungs compared to atmospheric pressure. So I have a high pressure out here, and let's just say it's 760. We'll assume we're at sea level. And here we'll just say it's 755, right? So because there's higher pressure in the atmosphere, this is millimeters of mercury, higher pressure in the atmosphere than there is in the lungs, gas will flow in, right? Hopefully you sort of see this. So as the diaphragm contracts, we're going to cause more suction pressure in the pleural cavity. That will then cause the lungs to expand. That will then change the atmospheric pressure to negative compared to atmospheric pressure, and therefore gas will then flow in. We're creating a negative pressure in our lungs to breathe, right? So this is what's called negative pressure breathing. This is how you and I are currently breathing right now. When we put someone on positive pressure ventilation, the opposite happens. We're going to create positive atmospheric pressure by the ventilator and push the gas in. It has nothing to do with your diaphragm, nothing to do with your pleural space. We're just going to push it in, right? So completely different from spontaneous breathing, like what you're doing right now, compared to mechanical ventilation breathing. Okay, so hopefully, and we'll go over this more in chapter 2 as well, we have the increased thoracic volume decreases the pleural pressure, which then the pleural pressure pulls the lungs out, which increases the volume of the lungs. And then we have that pressure gradient, then gas flows in. Once again, we have the diaphragm contracting, which creates more negative pleural pressure. The pleural pressure becomes more negative, it becomes more vacuumous, which then pulls the lungs out, which then creates an increased volume that creates decreased pressure, thanks Boyle's law, and gas will then flow in. So now you've learned today that you're breathing because of Boyle's law. Isn't that cool? All right, so this is the accessory muscle of breathing. So the accessory muscles of breathing, and you do need to know this, I will evaluate you on this later on. Muscles for inhalation, accessory muscles of inhalation, and accessory muscles of exhalation. So when you're looking at this, I'll ask your external intercostals, what are they doing to your rib cage? Well, they're pulling your rib cage externally, which will then make you breathe in deeper. Your diaphragm, right, when contracted, moves down, causes you to breathe deeper. Your scalenes, your sternocleidomastoids, that was my accessory muscle choice during my asthma attacks when I was a kid, all pull the rib cage. Notice all these things will either allow the rib cage to pull out with the diaphragm or pull the rib cage out directly, like your external, right? It's pulling your rib cage externally. All these will pull on your rib cage to allow for a deeper breath. So if I walk into a patient's room, or let's say a 7-year-old with a severe asthma attack, right? If I walk into that kid's room and I see them using their sternocleidomastoids, right? That neck movement and their scalenes, and they're using all these muscles, it tells me that they're having a hard time getting gas into their lungs. They're having a hard time breathing in, and they're trying to compensate for that. Well, what about exhalation? Well, exhalation normally is passive. Right? In other words, when you exhale, right, remember the pressure reaches equilibrium in your lungs, and then gas will then, your lungs then start to collapse, not all the way, but your lungs will start to recoil back to their baseline condition. And when that happens, you have positive alveolar pressure compared to atmospheric pressure, and therefore gas will flow out until you reach equilibrium with the atmosphere again. So at end inhalation, you'll reach equilibrium with the atmosphere, and at end exhalation, you'll reach equilibrium with the atmosphere. Isn't that crazy? So normally, exhalation, you don't require any muscles to exhale. Okay, normally you do not require any muscles to exhale. But let's say you are trying to blow out some candles on a birthday cake, right? Pretty important thing to do. So you can recruit your abdominal muscles, your intercostal muscles, your internal intercostal muscles that pull the rib cage in or down and decrease thoracic volume. So you do need to know the accessory muscles. Your book has, it's more in depth than this. Your book has a better one than what I have in the picture here, and I would go by the book one. But you do need to know the accessory muscles of inhalation as well as the accessory muscles of forced exhalation. Right, so forced exhalation also has like the pectorals and the trapezius. Those are all things that forced inhalation. Sorry, the pectorals and the traps can also be recruited to pull more gas. Okay, so the last couple of slides here. I hear celebrations when I say last couple of slides. This is the pump handle motion. So this is a person's facing to the side. So here would be their sternum, and back here obviously is their spine. So this is looking at the range of motion the rib cage has you breathe in from the side. So if you put both your hands on your rib cage right now and then take that deep breath in, you're gonna feel the ribs move down and out, right? You're gonna see it move this direction, right? You're gonna feel it move out. So down and out or up and out, right? That sort of movement anteriorly. Well, this is called that pump handle motion. So why is this important? Well, let's say we put someone in prone position. Let's say we put someone on their stomach. And there's many advantages to this, and we'll get into that later. But let's say we put someone on their stomach. What will happen to their ability for the rib cage to expand? Is it going to be decreased or increased? Decreased. It's going to be a lot harder for the rib cage to expand, therefore a lot harder for them to take that breath in. So it might actually make it harder for the breathing machine, when we talk about mechanical ventilation, to push in a breath because of the normal pump handle motion of the rib cage. However, we're usually exchanging that higher pressure for better oxygen levels in their bloodstream because there's more posterior segments. If you go back to all the segments, right? Go back to all the segments. How many anterior segments are there compared to posterior segments? Right? You have a lot more surface area posteriorly than anteriorly. So if we lay someone on their stomach, right, we put them in prone position, even though it makes it harder for them to breathe in or harder for the machine to push a breath into their lungs, we actually have a lot more surface area that's getting oxygen and blood flow that's not going to be collapsed because of gravity, right? Because gravity will collapse things naturally. Welcome to adulthood. Little joke. All right, next slide. The bucket handle is the lateral motion. So this is supposed to be the patient facing you, and you can see their spine coming around to their sternum. So this is sort of that side motion. So if you feel the side of your rib cage, right, you do almost like that chicken wing thing right now, and then take some good deep breaths. You can sort of feel that lateral up and down motion like that bucket handle picture. And so you can sort of see that dimension out. And so if you notice these things on a patient that's breathing spontaneously, this is just another application point. I know you love those, right? If you see a patient breathing spontaneously and you see them purposely, you see this sort of exaggerated motion, then that's a sign that they're working hard to breathe. There's something causing their breathing to not be normal. It's not normal to sort of see this motion be accentuated. It's normal to see it, but to see it accentuated means they're working really hard. There's something wrong. They could have a massive pleural effusion, and so in order to compensate, they have to create even more negative pleural pressure, right? And so they have to use even more of their muscles and go into respiratory fatigue. So you shouldn't see these blatantly on each other, right? If you have a significant other or a kid at home, don't be creepy about it, but see if you can watch them breathing, see if you can notice significant muscle movement or significant chest wall movement. Unless they're just ran on a treadmill or something, you shouldn't see much at all. So when you see someone's breathing working hard, like they just finished the Lord of the Dance DVD, right? Or their Zumba class, or my Zumba class, right? Then that's a sign that that patient might have a respiratory difficulty, especially if they weren't just exercising. All right, so we talked about inhalation, and we talked about the bucket handle, the pump handle motion. Let's talk about exhalation. So how does this go? So the exhalation, during exhalation, the diaphragm will relax. We talked about that before. So when it relaxes, what happens to the size of the pleural space? What happens to the size of the container of the lungs? They all decrease, right? You see the arrows going in. All of that stuff goes up and it squeezes it, which then increases intrapleural pressure, which then increases pressure on the lungs, right? The lungs are introverts. They get to go back and be introverts. Because the elasticity of the lungs going or snapping back into place, just like a rubber band, it creates positive pressure, because as volume decreases, which is what's going on here, what happens to pressure? Pressure increases. And so that's what's going on here. We're creating positive alveolar pressure. So that alveolar pressure increases, and then we have a higher pressure here. And let's just say it's 765. And then atmospheric pressure is 760. Well, that means we have a higher pressure in our lungs than we do in the atmosphere, so gas will then flow out of their lungs until we reach 760, until we reach equilibrium, and then hopefully we start the cycle over again for about a good 80 to 100 years. That's the whole point. So when we're looking at this, it's all about that pressure gradient, right? And exhalation is passive. It's letting the lungs snap back into place. The diaphragm relaxes. We've reached equilibrium on inhalation. Now the diaphragm relaxes. The pleural pressure then changes, which then changes the volume of the lungs to decrease. Therefore, pressure in the lungs increases and gas will move out. We'll repeat this again and again. If it's not making sense and this sounds like Greek to you right now, that's okay, right? You can rewind it, listen to it again, but we'll talk about this also more in chapter 2 as well. So normal exhalation is considered quiet, right? Normally you're not using any muscles. It's a passive process. That's a pretty important part to remember, because it's just your lung elasticity that's causing this. So let me ask you this. Someone has severe emphysema and it's destroyed the elasticity of their lungs. It's going to take them a lot longer or shorter to exhale if their elasticity is lost. It's going to take it longer for them to exhale because they lost that snap back. They lost that elasticity, right? It's like someone wearing a sweater and it's stretching it out. Well, I know it's a Seinfeld episode, right? Stretching out your sweater, and then is it as likely to go back to its normal position beforehand? No, it lost its elasticity, right? And so that's why one of the reasons why you'll see when we put people that have COPD on mechanical ventilation, we'll have to be very careful, because if we give them too fast of a breathing rate, they won't be able to exhale completely, right? And that's a bad situation too, because they lost elasticity, right? And you'll be like, oh, I learned this in pulmonary A&P. We need to set a lower respiratory rate for someone with COPD because there's less elasticity of the lung tissue, because normal exhalation is quiet or passive. Hey, there you go. Clinical connections. I love this stuff. You can force a breath out just like blowing out candles. Pretty important thing, but you're going to use your abdominal muscles, your obliques, your internal intercostals, your lats. All those things will help you sort of force that breath out. Yay, you made it. So please go through all the stuff, make any notes you need to make. You can re-listen to this section, or re-listen to the sections you need to. You can slow it down, you can speed it up. Please take the time you need to go through all this stuff. And like I said, I encourage you to sort of mentally go through, fill in the blanks mentally, either make 3x5 cards physically or do Quizlets, whatever it is that makes you sort of go through all this stuff and make sure you got the individual concepts down. Take breaks. Remember, only do about 45 minutes at a time. Take 15-minute breaks, or 50 minutes at a time. Take 10-minute breaks. and so let your brain reset in between breaks. But most of your studying, especially for this first part of pulmonary, needs to be recall. 50% of your study time needs to be recall, somehow recalling the information. If it's just reading and reading and reading, you will not do as well as if you spend half of it at least in recalling the information.